Okay. Okay, so the video is on. So this is the donor side of the surgery, and portal vein is already looped. So that's the cystic artery which has been tied and clipped, and then you gently sling the hepatic artery. So the main part here is not to use diathermy as less as possible, so that you don't get any damage onto the artery, and then you just try and loop it. So you don't do a lot of dissection around the artery in the initial hilar dissection. That's, I think, important. And once you're done your transection, and when you're going to come back onto the hilum, that's when you do rest of the dissection of getting the artery cleaned up. So this is the transection being done, and now this is the artery which we're going to just get the length on this artery. Again, most of this is by the Caesar, very minimal use of diathermy, so that you don't damage onto the intima on the adventitia as well. And most of this are lymphatics. The important thing is, if you have a small branch here, which may be, you need to be very careful that you don't get a injury on that branch, because that will actually start dissection into the donor artery. So that's very important here, to take precaution that you don't damage any branches here. Just be careful, and then you get a good length into it. And then what we do is we just tie and doubly clip. So one and two clips onto the artery, and one on both the sides of the tie, and then cut it out. Okay, so that's on the donor side, to make sure that you don't get any injury onto the donor artery. This is coming to the recipient artery. So what our favorable this one is to use the left hepatic artery rather than using the right artery. There are many reasons why we do this, and you have to dissect out the artery. So before doing the anastomosis, the important thing is to make sure that you got a good preparation. So you have to make sure that the lens and all are good. So this is the common hepatic lymph node which was taken out, and just trying to gain the length onto the left hepatic artery. Again, not much use of diathermy here. Most of the dissection is with Caesar. And then once you got a length, then you just try and see that you got adequate length. So I tend to keep the anastomosis as straight as possible. So I don't like to have kings or anything onto the anastomosis, and I just tend to keep it as straight as possible. And then the coming down to suturing technique. So what we do is we just do a clockwise suturing. So we'll start at the 3 o'clock. That will be our stay suture. So we'll take bites on both the sides, and I'll show you the bite. So it's important to prepare the walls well. We perfuse it with the heparin hapsaline, and then have a very good cut of the cut end of the both the on both the sides. Okay, and then you can gently dilate it, and then start suturing. So this is the first bite taken at 3 o'clock on the donor side, and 3 o'clock on the recipient side as well. So we'll tie this out, and then keep it as a stay there. Okay, then what we do is we do the posterior wall, and so that's the bite on the 4 o'clock. And so inside out on the donor side, and again inside out on the recipient side as well, with the double end needle. And then you just tie it off, and then you come up to the 9 o'clock position there by taking. So it is normally, it will be about 2 sutures, 3 sutures, and then you will be up to the 9 o'clock. So with this technique, there are several advantages. That if you have a discrepancy, you can see there's a discrepancy between the recipient artery and donor artery, and you can adjust the discrepancy very well with this technique, because the way you are taking the sutures. Okay, and so there is no rotation of the artery as well. So once you come up to the 9 o'clock, then you will do the anterior wall of the artery there. So I find this again, because nowadays many patients, most, about 50-60% patients are with Nash and Messerly. So they have thick arteries, their entimas are not very good. But if you have this technique, you don't have to rotate the artery and all. This actually works very well in those situations as well, and especially when you have discrepancies in the arteries. So the reason to use left arteries is basically, when you're doing the hilar dissection, you can isolate the left artery very well. You don't need to dissect the artery from the bile duct, because for right artery you will have to do all the dissection to take it out from the for anastomosis. And so it preserves the blood supply onto the bile duct as well. And obviously it is more straighter in length, so it will be running across the portal vein, so that actually gives a good this one as well. There is no kink or anything. We've done an RCT on this, left versus right. So I'm just analyzing the data, so we'll know where we are in terms of what are the benefits of using left artery. And this is coming to the anterior wall. So again, you just start from the 3 o'clock and then run. So this will be again 3 or 4 sutures, all inside out bites, and then you just tie off in the end. So what we're doing with this is we're just going to hold about 2 or 3 sutures. So there are not many sutures you need to hold on to while you are doing this anastomosis. So posterior wall, everything has been cut out, and then anterior wall, only 2 or 3 sutures you have to keep in order to. So there is no pull onto the sutures. The assistance required is very minimal for this technique. So these are the advantages of doing anastomosis with this particular technique. So this is tying off the anterior sutures, and then taking out the bulldogs and looking at the flow. So you can see the artery is straight, and there is a pericolitical spurt there. You can see that that's a good flow through the artery. And obviously you'll do an intraoperative Doppler to make sure that you got this good Doppler flow. And obviously we use piperine onto the artery to make so that there is no spasm or anything. So that's about the standard one. Now there will be situations when the artery is dissected, the recipient artery get dissected. So that's one important thing, how not to have a dissection on the recipient artery. And okay. Okay. So the way to prevent is when you're tying the one is you should be very careful in terms of your assistance not pulling the onto the hilum too much, because that happens very commonly. The surgeon is trying to have more this one, and then assistance is pulling it too much, and then you get an dissection into the artery. Then second thing is when you're tying the artery, so there are various ways described. What's best is just to go as high up as high possible in the hilum and just tie it. Sometime if you feel that the artery is too frail, maybe just put a bulldog first and then tie it, and then clip it and cut it out. That's the best way to do it in order to prevent a dissection onto the recipient artery. Now many times in spite of having those precaution being taken, still because of the various reason you can get a dissection, and then you do need to identify this intraoperatively. If there is any, if the intima is not in place and you had got doubt, you need to do a back cut on the artery and make sure that you got a healthy vessel wall to and do the anastomosis. And in some of these cases, actually, like in this case, we had both right and left. We had a look and we thought that they are not good, so we just actually gone back and we're just trying to get the GDA up in order to do the anastomosis. GDA is a very good option because the way GDA is actually lying there and it is surrounded by the tissue, most of the time the dissection won't actually extend up to that level. And in this, when you're trying to do this, obviously you will have to mobilize the common hepatic artery as well in order to get a length there. So this is GDA being mobilized, and then obviously once the GDA is mobilized, then you can turn it up, and then you can do the anastomosis onto the donor artery. So that's one way of dealing it. And if the dissection is extended down, then you will have to come up to the common hepatic. And then if common hepatic is gone, then you will have to look into epiploic or something else. I never had that bit of problem where I have to do an anastomosis on epiploic, but these are the options which are. And then in those situations, maybe if length is not there, then you will need to have a conduit done in order to get the length. So best is not to have these problems, and obviously prevention is always better rather than actually getting into troubles like this. Okay, so it's just about being careful while doing this, and most of the time you won't have problems. So I'll just move forward a bit. So that's the length of GDA we got there. Yeah. So again, this clip here, I just like to keep two clips and then divide it. And then that can be turned around to do the anastomosis, right? So the same technique will be used for the anastomosis as well. Now I'll just so we have published about this technique. This is a few years ago, and we did. This was obviously a retrospective analysis, and we compared with the technique where we used to rotate, do the rotation, and then do the anastomosis. So we'll do the anterior wall and then rotate and do the posterior wall, and we compared it with this technique which we are using. Obviously there is an era effect into this, but this did show that there was a benefit in terms of decreasing hepatic artery thrombosis rate. So this paper actually was also about it is not just about heart, it is about related complications as well. So this included spasms and other problems like steels, and also those things were included in that paper as well. Okay. And if you have a problem post operative, so best is to detect early. So we what we do is we do a Doppler ultrasound morning evening in all patients for first 7 days, and then after that every day for the first 2 weeks. And if there is a suspicion, then obviously on Doppler, then we'll do a CT to make sure that what exactly is happening. And if it shows, there can be non-thrombotic complications as well, which we need to be keeping an eye. So don't rush into that everything which is related to artery is hepatic artery thrombosis, and get tempted to re-explore everything. Okay, so if it is vasospasm, then again intraarterial NTG is, if it's a steel, then you have to do a splenic artery embolization, and if just a low flow, then anticoagulation can suffice. Obviously, if it is had within 5 days, then we tend to explore actually and do a re-anastomosis, revascularization. And if it is more than 5 days, then it is about intervention radiology. If any one of those fails, then obviously it depends on how to deal with it. So with this, actually, we the data we were able to salvage almost more than 80% of the livers, and the biliary complication, although was higher among the ones who had hepatic artery related complication, that was around, I think it was around 20% or 25%, which was significantly higher than the ones who didn't had a biliary complication. Sorry, hepatic artery related thrombosis. So that's about my brief. Thank you very much. Thanks a lot.